wonderful evening, and with a good number of participants despite the load shedding. How's the weather on your side?
It's actually quite nice. We're having kind of an extended summer today. This is our fall, and it's actually quite nice. We're gonna have a very warm day, beautiful, cloudless sky. So
that's wonderful.
Quite nice. Yeah,
that's wonderful. I hope it doesn't signal the fact that you're going to have an awful winter, because you get snow in the winter, don't you?
Well, we're in Southern California, so we're it's quite arid. We have a similar situation, like Dietmar was explaining about droughts, and we're 10, 11 years into a drought as well. So it's pretty arid. I live about 2,000 feet, so we have the opportunity to have within 30 minutes to be up at 6,000 feet up in the pine trees, or down at the beach, or in about 30 minutes, or be in the desert. And so we can pretty much pick our climate from where we are here in San Diego.
Yeah, gosh, that's wonderful. Gosh, well, the number of participants is climbing steadily. I'm going to give it another 2 or 3 minutes, and then Steve, I think we should get going. Your presentation's important. Good, there we go. Okay, Steve, I think I'm going to get things going, and hopefully we'll get more and more participants. It's a Friday evening in South Africa, of course, so with load shedding, it's a double whammy in terms of participation. But be that as it may, let it not dampen our spirits. Right, let's see. There we go. So Steve,
yes,
to everybody that's in attendance at the moment, welcome. I'm very honored and privileged to introduce our colleague, Dr. Steve Olmos. I'm never quite sure whether to say doctor or professor, because I do believe you are a professor, aren't you, Steve?
Yes, I was had a position at the University of Tennessee, but now I'm limited my time to practice and education, to general education services, like what we're doing tonight, just sharing information.
Well, the reason I asked that question, Steve, was because I've come to know you as a very humble person. So if you don't mind, I'll address you as Professor Steve Olmos. Good. So before we get going, everybody, I just have a couple of announcements to make. First of all, please refrain from using the raised hand, but type your comments and questions in the Q&A tab at the bottom of your screen. CPD, continuing professional education certificates, will be loaded onto the SADA platform, and you'll be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access your CPD certificates. The event for tonight qualifies for 1 clinical CEU. However, there is a slight catch to it. Remember at the end of the webinar to complete the evaluation questionnaire. Otherwise, you won't get your CPD points. So please don't miss out on that. Then upcoming webinars on the 11th of November. This is TMJ Awareness Month, and Dr. Mark Mayer will be giving a presentation on temporomandibular joint disorders, a foundation for diagnosis and management. Good. So before we get going, I'd like to just officially introduce our guest and presenter, Professor Stephen Olmos. Stephen is an internationally recognized lecturer and researcher, and the founder of the TMJ and Sleep Therapy Centers International. He has dedicated the past 30 years to the fields of craniofacial pain, TMD, and breathing disordered sleep. He has extensive postgraduate education and board certifications in both craniofacial pain and dental sleep medicine. He is currently directing research in these fields through data collection at over 60 TMJ and sleep therapy centers spanning 7 countries. This effort is focused to establish protocols between dentistry and medicine for optimal treatment outcomes. Steve, we really look forward to your presentation this evening, and we're really privileged to have you give us your time. And we look forward to it, and good luck, and I'm sure everything will go very well.
Thank you. I really appreciate that. It was a very nice introduction, and I'm so happy to have the opportunity to share some thoughts with everyone in South Africa. It's isn't it technology amazing that we can be on opposite sides of the planet and be able to share an evening of education. So I hope I can contribute to your knowledge base tonight. Yes, I'd like to speak to craniofacial pain, orthopedic problems of the jaw, and breathing disorders because they're all so highly comorbid. And it was a beautiful introduction, and that's really my background. Is one, I feel that a person should have an awareness of all different perspectives. As we know, there's so many different philosophies on how to treat these kinds of problems, and they all have their merits. And so that's why I've exposed myself to every different type of philosophy, and taking board exams and to ensure that I have an understanding, and then try to meld the best components of that, so that we can come to this established system. And that's what I've done over the last 30 years. My practice here at San Diego is limited to treating neuropathic disorders, muscular disorders, orthopedic problems of the jaw, primary headaches, migraine tension type, cluster type headaches. Basically working with neurologists here to figure out why people's head hurts when the MRIs come back negative. You have to establish a triage system for screening musculoskeletal from systemic problems, and so that's the system that we have. And of course, they're so highly comorbid with breathing problems, and so that's what I really want to address tonight, is that comorbidity. How we go about doing that is focusing on inflammation. Inflammation is a precursor for all pathology. So if we can reduce inflammation early on, and it sounds silly enough, but produce inflammation later on, we actually will have a system for organizing the body to heal itself. The parafunctional activity that then produces the inflammation has to be addressed. And then, of course, finding the origin of that parafunctional activity is key. And very often, breathing disorders are highly comorbid, and very often the origin of a lot of the parafunction. So if our airways collapse when we're unconscious, if we do not have proper nasal breathing, then we're going to have orofacial consequences. And that's what I really want to talk about tonight. And the thing that most people have difficulty with is nutrition. How do we have a diet that does not inflame us, which just adds another layer of difficulty? So, these are all the things that are important. So we combine that with decompression of the jaw through oral appliances, treatment of airways. And then, of course, we've got physical medicine techniques using laser injection techniques. We've got a whole array of medication, thought processes. And so all of this is combined, and our treatment time is anywhere from 10 to 12 weeks to be able to control these kinds of situations and basically therapeutically rehabilitate these injured structures. So the thought process is it is not possible to separate orthopedic problems of the jaw, facial pain, headaches from breathing disorders. And that's what I want to talk about today, is the comorbidity. I produced a system where, regardless of the origin of the appointment, whether it be a pain, primary chief complaint, whether it be some disturbance of sleep, whether it's some kind of orthodontic process, those have huge overlap. The people who have disturbed sleep have some level of pain. The people who have facial pain usually have some kind of problem with breathing. The people who have crowded teeth all have problems with breathing to various levels. And so that's why we have a comprehensive evaluation system, regardless of the reason for appointment, to be able to triage what's a breathing problem, what isn't, what's an orthopedic problem, and how we go about treating those. For the ones that the jaw problems are primary, that contribute to daytime symptomology, well, then we would decompress those people day and night. And in our hands, in about 10 to 12 weeks, we're able to wean them off of any daytime decompressive appliance at about 95%, which means they do not need any other kind of dental therapy for their problems. And this is the thought process that I've mentored all of the over 60 offices throughout the world, where I've personally mentored them in these techniques. We work together. I've been to their office. They've been to my office here in San Diego. And so we've established a standardized protocol so that we can then publish the results of the findings of what we see. And that kind of research is quite powerful. Instead of a localized place, we've done this throughout the world. So we're throughout the U.S., throughout Canada. We have a center in New Zealand. We've had 4 centers in Australia. We have 3 centers in the U.K. We have a center in Dubai and Bahrain. So we're spreading this message, and we hope, and I hope someday, to have an office in South Africa, so that we can standardize and deliver this information and share it with the world. When we look at the comorbidity between obstructive sleep apnea and cardiovascular disease and dysfunction, we see that there's a very, very high overlap. And I don't think there's any more literature that connects those 2 points. In fact, our American Heart Association is reaching out to the cardiologists and saying, listen, OSA prevalence is as high as 40 to 80% in patients with hypertension, heart failure, coronary artery disease, pulmonary hypertension, atrial fib, and stroke. Despite its high prevalence in patients with heart disease and the vulnerability of cardiac patients to OSA-related stressors and adverse cardiovascular outcomes, OSA is often underevaluated, undertreated in the cardiovascular practice. So our American Heart Association is reaching out to cardiologists and saying, why aren't you evaluating all your patients for sleep breathing disorders because of the extreme high comorbidity? There's an oxidative stress that's produced from breathing disorders, destatting from the oxygenation, but the real mechanism is arousals. Every time a person is disturbed from sleep for a respiratory effort-related problem, produces cortisol, and that cortisol produces inflammation through oxidative stress. And so this kind of inflammation then produces increase in coagulation, atherosclerosis, and left atrial enlargement. And this leads to hypertension, atrial fib, heart failure, coronary artery disease, and pulmonary hypertension. So these are the things that we end up succumbing to, but the origin, it very often is disturbed sleep. I think we can divide, there's 4 components of obstructive sleep apnea, and 2 of them are structural. We look at something called P-crit, so the critical pressure to collapse the airway, and also the collapsibility of the airway based on muscle tonus. So those are things that we can affect with oral appliances and different types of treatments that we have. But then there's a neurologic component to it. And the neurologic component is, how do you respond after you haven't had a breath for a while. And so this is loop gain. So do you have high loop gain? Do you hyperventilate, which only expends more CO2, which actually lessens your ability to oxygenate yourself? So that's why high loop gain can be an issue. What's your arousal? How quickly do you wake up when you don't breathe? So if you have a low arousal threshold, then you can go long periods of time without breathing, and this can be detrimental. Our American Academy of Dental Sleep Medicine had a meeting just a few months ago, and this was an excellent lecture by Dr. Lau. And I'd like to share some of these slides because I think it's very important that we understand these components. This is called the PON scale. So P meaning P-crit, the collapsibility of the airway. Is that high? Do you have a high collapsibility? Not good. And arousal threshold. So how do you, if you don't respond to respiratory distress, then the longer you go without breathing, the more hypoxic your tissue becomes. And of course, that's going to be, could be lethal. Loop gain, we spoke about, do you have an exaggerated reflex? And of course, muscle response. So there's lots of ways to treat these different disorders. So we have muscle function. We can use oral appliances, position sleep. Certainly losing weight is going to be beneficial. Surgeries and positive pressure are all the things that affect the P-crit and the collapsibility of the airway. Are there things that we can do to assist that? Yeah, myofunctional therapy is helpful to reduce this collapsibility, give tonus to the airway. There's medications that can be addressed. And then, of course, we have the neurologic component, the arousal threshold, and we have medications for that as well, and about sensitizing us to loop gain, to be more sensitive. And there's other ways so basically, arousal threshold and loop gain, which are neurologic components, are really our sensitivity to CO2. How sensitive are we? Are there ways that we could then make ourselves more sensitive? And yes, buteyko breathing, nasal breathing, these kinds of things can make us more sensitive to CO2 and perhaps not be reliant on medications. There's an excellent course that's given virtually by Roger Price in Australia. And Roger's allowed me to use a couple of slides from his presentation. And I'd really encourage everyone to take a look at his Breathing Well Online Academy. Very well done. Explains the process of respiration. And that's what I'd like to speak to now. Because atmospheric oxygen is about 21% of the air, but only 0.03% of CO2. We only require 5% of oxygen to oxygenate and function, but we need 6.5% of CO2. So we have to produce CO2 in order to maintain CO2 levels between 38 to 42 millimeters of mercury. And our breathing rate, if we're breathing through our nose, is very slow. We have 8 to 10 breaths per minute using our diaphragm. The volume of air is between 4 to 5 liters per minute. And if we do this, we're able to sustain the CO2. If we have CO2 at these levels, then we can disassociate oxygen very effectively. And that's called the Bohr effect. And so if we lose CO2, we actually lose the ability to utilize the oxygen that's carried in our hemoglobin. So, and so this is very important that we understand that nasal breathing is also restful to our nervous system. It establishes a parasympathetic function. So we have normal secretions and normal function and optimal, pH of our saliva and our blood, so that we can reduce bacterial infections and have the proper microbiome. And so there's a homeostasis. This is an article that came out in OOO back in 2009, talking about what happens to your nervous system when you breathe properly. Results indicated significantly more activity in the temporalis and suprahyoid muscle regions, as well as a significant reduction in heart rate variability when the tongue was positioned on the palate compared tongue position on the floor of the mouth. So if you can breathe through your nose, you should be able to close your mouth and your tongue should immediately rest on your palate. And if it does, then you are properly nasal breathing. If you have nasal obstruction, your tongue will go down to the lower anterior teeth. And that's why we see so much anterior crowding. And the effect of mouth breathing then changes the volume of and the rate at which we need to bring air into our bodies. So we still need the 5% oxygen and 6.5% CO2. But if we're mouth breathing, we're losing all of the CO2, which means we have to take in greater volumes of air. So the breathing rate is increased to 16 to 20 breaths per minute. The volume is increased to 8 to 10 liters per minute. And as a result, we're using the upper portion of our breathing, upper chest rather than abdomen. And so we dip the levels of CO2, which means we have less ability to use the oxygen to disassociate the oxygen. So just in exercise or in just function, we're going to be out of breath very quickly, and we're going to be hypoxic. So tissues are not going to have the proper oxygen levels they need in order to function. And posturally, we're going to change. We're going to have a forward head posture in order to maintain an airway, much like we do for CPR, where we're trying to establish an airway. So the body does that, but then there's consequences. You're going to have increased pressure on the cervical and lumbar spine. For every inch the head is forward of the shoulder, you have 10 pounds of weight added to those structures. So because of the cantilever. If we look at the ENT, the ear, nose, and throat literature, otolaryngologists, we see that nasal involvement in obstructive sleep apnea is quite high. The nose accounts for over 50% of the total upper airway resistance and plays a role in the establishment of the physiologic functions of humidification, heating, and air filtration, and also mixing with a gas called nitric oxide. Nitric oxide is concentrated in your sinuses, so every nasal breath brings this gas into your lungs, which is antimicrobial. So it kills virus, it kills bacteria, it's your immune system. It also causes peripheral vasodilation. So every nasal breath lowers your blood pressure. So it's important nasal function, and there are consequences to bring air into your lungs through your mouth unfiltered. And this is certainly of consequence now that we're so involved and at the consequence of COVID. It's more important than ever to be able to use our immune systems. And that's where we're limited. So this is called the Starling resistor model. So the more narrow the cartilage is at the first point of entry of the nose, and of course the trachea and the soft tissue in between those 2 points is going to be affected. So the more narrow either endpoint are, the greater the extraluminal pressure to close your airway. So having a patent nasal breathing gives optimal oropharyngeal function. We published a paper back in 2016 that was the first to link headache and jaw locking comorbidity with daytime sleepiness, which is a consequence of nasal obstruction. And we used the data from 11 of our international centers along with the University of Tennessee. And we used the Institutional Review Board from the University of Tennessee to publish this paper. We had almost 1,200 patients in this study, and we used the Epworth Sleepiness Score, which is the subjective evaluation of daytime sleepiness, which is pretty much an industry standard to evaluate people's fatigue. We also have a questionnaire where we ask patients, regardless of their point of entry, if they're coming to our office because they have sleep disturbance, if they're coming to our office with pain, it doesn't matter. We ask them questions about pain and sleep disorders, sleep disturbances. And as a result, I think that's why we were the first. Most people come in with concerns about pain, and then we ask them questions about pain. Or they come in with questions about disturbance of sleep. So we ask them questions about that. I think the combination of asking both is why we were able to find that an Epworth score greater than 6 is going to result in an increase of headaches and jaw locking at an incidence of about 1.39 times greater. So understanding how the nose functions and understand the first point of entry can dramatically affect the function of the nose, but also chronic craniofacial pain is something that I think we're very early into seeing. So this is a paper from the Otolaryngology Journal showing what's called a nasal valve compromise, and that's this area here where the cartilage is bulged in internally and blocked the nasal valve. That's what this is showing. And if you look at flow rates, you'll see in this graph here that blue is a very slow flow rate, where the red would be very high. And they're showing that on the side where the valve was impinged, that the flow rate to the olfactory area where you would smell is severely compromised. And so if we understand how a nose works, that really the highest flow rate, as you can see here, is in the middle turbinate area, not the inferior. So many people with nasal obstruction, when they go to a surgeon, have the inferior portion either removed or altered, when it's really the middle area that is the important part. And I think that's interesting to me, and working with a lot of ENTs, how they're changing their focus now that they understand really the purpose of nasal surgery is to restore function, not to remove simply parts that may not be optimum. And I think that philosophy is changing. It is certainly with the ear, nose, and throat doctors I work with. This is a paper that's going to come out in another week or so that we put together. We had almost 1,400 patients in this study, and we were looking at the relationship between nasal obstruction and facial pain. And we were wondering, well, what portion of the nasal obstruction might have the greatest impact? So we looked at nasal valve compromise, we looked at soft tissue swelling, deviated septums, concha bullosa, which is a expansion of the middle turbinates that then blocks breathing. And we tried to find any correlation, and it was substantial. What we found is that the first point of entry, nasal valve compromise, was almost 7 times greater risk for having facial and cervical muscle pain. So that's quite profound, and I don't think anybody's ever published that before. And this is going to be very, very big in the ENT literature, the otolaryngologists, as well as dentistry. If we understand that so much of what we're treating in the facial pain problem is a result of aberrant breathing, that gives us a whole nother treatment modality and a thought process. So this is very important. These are all the centers that contributed to this paper. So then we look at dentistry. We look at, well, how stable is it how we arrange teeth? So orthodontic therapy is found to not be stable. Certainly in this 8-year follow-up published in the orthodontic literature, demonstrating the fact that occlusal relapse can be expected after orthodontic treatment, irrespective of long-term use of fixed retainers. So our thought process is that we arrange teeth, but we don't do anything about the origin of how they got crooked in the first place. And very often what we have is you have nasal obstruction, you're going to have that tongue come down against those lower teeth, and then we're going to have these kinds of open bite and crowding. What if we do surgical therapy? What if we do orthognathic surgery and then bond wires onto these teeth, cuspid to cuspid, upper and lower? The orthodontic literature says, well, you know what, that fails too. And it's because we miss the point that this is actually a functional problem that we haven't addressed. This is not new information. In the orthodontic literature 40 years ago, Dr. Harville explained this to us when he put silicon in the monkey noses to then demonstrate all of these kinds of malocclusions, anterior open bites, and all these kinds of things. Now, the problem was that after he removed the silicon plugs, even though they restored nasal breathing, the skeletal problems remained. And that's really what so much of what we're dealing with. And that's why I wrote this article for the Journal of Orthodontic Practice, explaining why we have orthodontic relapse. As you can see here at the bottom, CBCT and the evaluation of airway, minimizing orthodontic relapse was the title of my paper. To explain, there's 4 points of potential obstruction in the airway. You have 1, which is the nasal valve that we spoke of. 2 is the nasopharyngeal area, soft tissue or skeletal problems. 3 being the oral, the velopharynx, the soft palate, which is the most narrow part of the airway. And of course, for the oropharyngeal component, all need to be patent. So we need to look in the mouth. We need to look at the nasal valve. Do we have a compromised situation? Do we have collapse when people inhale? Does their airway collapse? Do they have the middle turbinates that have pneumatized, demonstrating here in the middle, concha bullosa? Or do we have the immune problem with tonsils and adenoids swelling due to mouth breathing? And so I give examples in this article about this person here was an 18-year-old who had had orthodontic treatment and has his centrals fixed. 3 to 3, upper and lower were bonded together, but he still developed an open bite very quickly after orthodontic therapy because the x-ray shows he has complete nasal obstruction here, so he's mouth breathing. The patients, as they get older, this patient here is a 40-year-old dentist who has chronic pain. We take a look at the x-ray and then we can see elongated styloid processes. That's the result of parafunctional activity causing tension from the stylomandibular ligament and the stylohyoid ligament that then causes increased mineralization of those bones that can get to a point to be extremely painful. These are in patients that usually have apnea. So you can see the diastema just posterior to the cuspids. And the reason why the 6 anterior teeth are moving forward is because they're all bonded together after the orthodontic therapy. The tongue has pushed them forward as a unit. And so I asked this patient, have you noticed these diastemas, these spaces getting larger as time goes on? There's, yes, how did you know that? Well, that's the result of the tongue pushing. So I suspected a breathing disorder. Turns out this person stops breathing 40 times an hour. So these are the things that you're going to see. The purple arrow there at the distal of the second molar on the left-hand side shows a fractured cusp, and that's the result of clenching from these breathing disorders. So again, we really can't separate these problems. The literature shows us, this is an NIH-funded study that our government has supported to find the link between obstructive sleep disorder and TMD. And what they found is they took 2,600 people who had OSA and 1,700 that were diagnosed with jaw joint disorder. And they found that if a patient has OSA, they're 3.63 times more likely to have TMD. Both studies supported a significant association of OSA symptoms and TMD, with prospective cohort evidence finding that OSA symptoms preceded the first onset of TMD. And that's essentially what I have assimilated in this article that I was asked to write for the pulmonary journals. I was lecturing in the UK in London, and at a physician sleep meeting, and they asked me to write an article about these comorbidities between facial pain and sleep apnea. So this article here talks about the relationship between OSA and TMD. It talks about the relationship between OSA and primary headaches like migraine, tension type headache, and cluster headaches. This article talks about fibromyalgia and its relationship to OSA. Insomnia, 50% of insomnia is related to chronic pain, producing cortisol that prevents you from getting to sleep. And then, of course, a sleep-related bruxism and forward head posture. The more frequently you stop breathing, the more forward head posture that you have, and that produces daytime symptoms. So in this article that I'm showing you, we've got over 80 medical literature comorbidities and articles that show these links. So I think this is a very good paper that you might want to take a look at to understand how all of these things come together. As dentists, we're looking at the endpoint. We have patients who are wearing down their teeth, and so they ask us to help them to be able to address this issue. And so what we need to understand is that grinding your teeth is a dental manifestation of a medical problem. Sleep bruxism is in the same category as a restless leg or periodic limb movement. The American Academy of Sleep Medicine categorizes sleep movement disorders in that way and lists sleep bruxism in the same category. So we need to understand that a parafunctional activity at nighttime may have a respiratory origin. It can be the result of pain. It can be the result of both. And so we need to have a specific understanding of that to optimally treat it. And night guards, we're going to see, are not the optimum treatment for a lot of these problems. What the literature now shows us, and this is a paper from 2019 from the Journal of Orofacial Pain and Headaches, that says that about 1/3 of adult OSA patients had sleep bruxism, and these patients demonstrated significantly more respiratory related arousals and oxygen desats. So this means that if we have patients who are grinding their teeth, we should be investigating whether or not they have breathing disorders, because how they're going to present is with abfraction lesions where we have flexion and loose mass at the interface to the bone. We're going to see worn dentition, fractured teeth, because proprioception at nighttime goes to the cerebellum. It doesn't go to the cerebrum. In the daytime, it goes to the cerebrum, the somatic brain. We can be conscious of our grinding when we're awake, but at nighttime, we bite 5 times harder. That's why things are fractured. And that's why the thought process was to use night guards for these kinds of situations. But now the literature shows that if a person is grinding their teeth because of a respiratory reason, then a night guard is going to make that respiratory problem 50% worse in 40% of the cases. And we see, paper after paper demonstrating this fact. So we need to understand that we should not be making night guards for people that have breathing disorders. And this is very important to be able to screen. So as dentists, we understand what's our role in sleep medicine. And this was defined in this medical journal, Sleep Medicine Clinics, back in 2010 by Dr. Bailey, who is a professor at the University of Southern California. That's where I graduated from. And he outlines what we should be looking for with patients who have sleep disordered breathing. So we should look at the tongue. Is it coated? Does that mean we're mouth breathing? Is it enlarged? Is it scalloped? Scalloping of the tongue is 70% predictive of obstructive sleep apnea. Does the tongue obstruct our oral pharynx? What about the teeth and periodontal structures? So if a patient has gingival inflammation, gingival bleeding when probed, dry mouth, gingival recession, or tooth wear or abfraction lesions, those are all signs of a breathing disorder. Okay, we should look at the airway. We should look at their nose, and we should look, most importantly, and this is surprising as dentists, that we should look at the posture of the head and neck. Do they have a forward head posture? Do they have loss of a curvature of their cervical spine? These are all things that we weren't taught in dental school, and we're not really part of our evaluation process. So then we look at, well, why doesn't orthodontic therapy be long-standing? So we looked at the orthodontic literature, AGO-DO, and they show that, we see cases where teeth are bonded together, but the tongue pressure has pushed the teeth apart. And if you read the article, it was more about the fact that perhaps the bonding wasn't well done. But if you look at CBC imaging, you can clearly see the teeth are being pushed out of the bone. And if you didn't know the medical literature that tongue scalloping is 70% predictive of obstructive sleep apnea, you wouldn't know that this mechanism. And I think that's where medicine and dentistry need to come together to be able to explain a lot of the things that we didn't understand as dentists, that we weren't prepared for. And I think this is very important. We should understand that there's high comorbidity between periodontal disease and obstructive sleep apnea. Some of these studies are finding almost an 80% comorbidity, and we see more and more articles linking that. Previously, we understood the relationship between obstructive sleep apnea and cardiovascular disease, but now we know the precursor of cardiovascular disease very often is obstructive sleep apnea or sleep breathing disorders. And so this article here outlines all the articles that link periodontal problems with OSA. And so it's a growing bit of literature that I think is going to help us as dentists be able to help our patients in a more comprehensive way with what we hope to be more stability and better care. But what about our education? So this is an article that was published in the Journal of Prosthodontics, and it was asking prosthodontic program chairs what, how much education are we giving our prosthodontists? So they had about 94% of these prosthodontic educators are using oral appliances to treat sleep disorder breathing. 80% use customized oral appliances. 68% of the programs do not have a dedicated course for snoring or sleep apnea. Only 48% of the programs regularly address sleep apnea. And that's quite sad, as educators and for our profession. We'd like to believe that our universities are preparing us for care. I think we're doing a good job in the restorative aspect, but I think we need more education on how we can help people with breathing disorders, because we have all these treatment options. Certainly there's positive pressure, there's surgeries, there's oral appliances, hypoglossal nerve stimulators, certainly exercise, weight reduction, and then hybrid therapies. And so I wanted to speak to this here because of all the different things that we can use. So what's the treatment for? What is the best interface for patients? And certainly very often sleep physicians are going to go to positive pressure. So CPAP, BiPAP, AutoPAP. But here's the problem: 46 to 83% of patients are non-adherent. So even though it may be beneficial, it's not something that's utilized. And what is the key component that is the issue is the mask. And I think the reason that people have so many problems with air leaks and irritation is the fact that no one evaluates the nose to see if it's possible to push air through it. If we're going to use oral appliances, what are the two greatest points that are going to limit our success? And that's nasal airway resistance and BMI. So if we can reduce people's body mass index, in other words, lose weight, and we can establish nasal breathing, those are the two components that are likely to ensure a good result when treating with oral appliances. Again, some slides from the American Academy of Dental Sleep Medicine's meeting. Dr. Sutherland talked about the direct relationship between CPAP. There's no question CPAP is more efficacious, but there is greater adherence to oral appliance therapy. And if we look at the literature that for long-standing evaluation, we'll look at papers that say, here's all the different kinds of appliances that we can use. And what happens to people's orthopedic relationships? So they're showing here that over 20 years, eventually what happens, if you look at the top row there, you'll see how retrognathic that mandible is. But 20 years later of treating the breathing disorder, it becomes class 1. So isn't it interesting that the longer you treat a breathing problem, the more normal the orthopedic and dental relationships are? overbite decreases, overjet decreases, and you go from a class 2 tendency to class 1. Isn't that interesting? It gives us some insight as to why we develop these orthopedic problems in the first place. And so if you look at a direct head-to-head between oral appliances and positive pressure, this paper is specifically that. They took patients who had moderate apnea at about 25.6%, 6 times an hour that they would have issue. And certainly the CPAP had better outcomes with the reducing AHI to 4.5, where the oral appliances reduced it to 11.1. Interesting that the arousal index was actually lower for CPAP at 16.6, but about 19.2 for oral appliances. But if you ask the patient when they woke up, did they feel more rested with the CPAP or the oral appliances, you'll see that the oral appliances actually had a lower Epworth scale. So interesting that people feel more comfortable. In a head-to-head, the dotted line is CPAP, the solid line is the oral appliance, and you can see the reduction of AHI is certainly a bit greater for CPAP, but symptom control is the same. In other words, your health benefits from lowering blood pressure and cardiovascular disease are the same whether you use CPAP or oral appliances. Adherence is superior with oral appliances. Tolerance is better. Patient and partner acceptance is better. Convenience is better. And affordability is about the same. So those are really the crossover. So the things that as dentists we are concerned is with bite changes. How often is it likely to happen that we end up with a posterior open bite? Well, if we look at the literature, we see that this happens at about 18% of the time if you're using certain techniques. And the techniques that are most often utilized are a George gauge technique. And this somehow has been adopted from an orthodontic construction bite, now has been adapted to a technique for treating sleep breathing disorders. This is kind of something that people have utilized, but they don't understand that very often we have patients that have a significant cant of their occlusal plane and their jaw. And we see this all the time. That's why we have unilateral disc displacement issues. And so if you have this mandible in space with a certain occlusal plane, and you put a rectangular box in there to disassociate those things in order to get this relationship, and then you protrude the jaw 60% as a starting point, is it any wonder why we're going to have a unilateral disc displacement and a posterior open bite? So I don't subscribe to this thought process. We need to think in 3 dimensions. We need to understand volume changes, and you don't have to move the jaw in a linear way in order to accomplish that. This is what was told us back in dental school when I was in dental school in the 70s. Earl Pound was publishing Let S Be Your Bite using phonetic techniques in order to set our denture teeth. And then, of course, set the posteriors in that relationship would be ideal. So using a phonetic technique corrects the cant. And that's what we see in the literature. So thinking in 3D, thinking of pitch, roll, yaw is really important for us to have in our conversation, in our jargon. Dentists have used linear concepts for a very long period of time. Protrusive, lateral, vertical. The jaw does not work in linear pathways, and neither does the oropharyngeal airway. So when we address this issue, whether we use maxillary mandibular advancement, which is very effective in treating severe OSA, or whether we're using an oral appliance or any technique, what we're really doing is we're giving tonus to the lateral pharyngeal walls and preventing collapse. And so a way to measure that, and I found this interesting, this is an article that just came out a couple months ago, talking about acoustic pharyngometry. as a new method to facilitate oral appliance therapy, so that you can use this technique. It's basically sonar of the airway, so you can manipulate the jaw for optimum function of your oral appliances. And I thought this is really quite funny. I don't know how much of a literature research they did, because I published this many years ago. This is in 2007, where we published physiologic technique using this same acoustic pharyngometry. So I don't know, they may have needed to do a little better literature research, but we were able to take this information and create a 3D representation where we could quantify the differences. And the interesting thing about an airway is, for every 1% increase in volume, you get a 4 times greater increase in flow rate. And so this is quite powerful. You don't think of 1 or 2% making a big difference, but it actually makes a very, very big difference. So this is the paper that we published, use of the sibilant phenome registration protocol to prevent upper airway collapse. And in this paper, we spoke of how to capture a 3-dimensional relationship using a round object and this using the pharyngometer to measure the optimal position to reduce collapse. And what we found is, in this population base, that we had a 25% collapse of the airway when we had them expend all the air. So breathing out, we would measure resting volume to collapse. And it was quite dramatic. Using the phonetic technique, we increased volume 12%, and we decreased the collapsibility from 25 to 16. And that's really what you're looking for in a position to be able to maintain airway. So basically, in a phonetic technique, you're not protruding the mandibles. You can see how the lower teeth are not protruded, whereas in the George gauge, that's what you do. So we did a study to compare the two techniques. And what we found is that there wasn't really a difference in efficacy, whether you use a phonetic or not. However, in a phonetic, you're not titrating. We had 0.8 times titration per patient, less than 1, excuse me. Whereas in the George gauge, it was 2.7. So you said, what's the big difference? 2.7, 0.8. Well, when you've already protruded the jaw 60% of its limit, and then you protrude it even greater, that's where you run into risk. And so to basically visualize that, here's a patient in a habitual position, and you can see the relationship, and then you can see how the jaw has been protruded in the George gauge, where you see the phonetic where it is not protruded. And so if you look at the orthopedic condition here, between what the CRCO compared to the phonetic, there aren't great changes there. However, the George gauge produces a significant change in condyle-fossa relationship. And if you look at airways in these different relationships, people don't really understand that as you move the jaw forward, you can be collapsing the airway laterally. And this is showing that even though you've protruded the jaw significantly, you've actually narrowed the airway. And so that's why you have to look at the orthopedic position along with the volume to have the optimal position, so that patients don't wake with jaw dislocation. And so that's what we're showing is relationships. This is a paper that was published just a few months ago in the American Academy of Dental Sleep Medicine. Dr. Ng is our center owner up in Manitoba, Canada, and he's working on his PhD currently and comparing the sibilant phenome technique to the George gauge. And so these are essentially the different techniques, one that does not correct cant, one that does correct cant, using this incremental bite stick that is in 1 millimeter increments to mirror that difference. And as a result, if you look at the position of the phonetic, you'll see that it's pretty much right in the middle of the envelope at a much a millimeter less vertical than the George gauge. And of course, the George gauge is on the outer edge of what is possible for protrusive movement. So you have to understand that likely if you have a cant and you've corrected it properly, then you should be able to see a bite relationship where there is greater posterior interocclusal space as demonstrated here on the left than the right. And that's how you've corrected the orthopedic relationship in the cant of the occlusion. And this is going to give you the biggest opportunity to recapture a disc, to get stability, and to control orthopedic dysfunction. And so, again, it goes back to making sure that all 4 points of obstruction are patent. We need to understand the history of oral appliance therapy. We wrote an article. Matt is our director of our laboratory. We have a laboratory that produces 3D printed appliances that we have been approved by our government for use in obstructive sleep apnea. And in this article, we spoke about all the different types of appliances, temporary and custom made, throughout the years, of how we have originated from acrylic type things to more bio-friendly materials like type 12 nylon, and to get away from clasping with ball clasp and these kinds of things that separate the teeth, that causes the diastemas that people complain about. And so there's an evolution and trying to find the smallest type devices that we can that are the most durable, and understanding the Starling resistor model that we spoke of earlier. So nasal dilation becomes important. And we need a device so we constructed one that's called the DDSO. This device allows for mandibular protrusion, vertical titration, and also has tongue lifters to manage the tongue, because very often people think about the jaw, but they're not understanding that the tongue can retract into the airway. And there's a paper that was published in the Journal of Dental Sleep Medicine just a couple of years ago, talking about if you manage the tongue. This one has wires that then lifts the tongue up and moves it forward, which is a bit crude. In our variation, we actually have very smoothly contoured tabs of different lengths, so that we can customize for a patient to their comfort and function what we need to do to manage the tongue, manage the mandible, and of course vertical titration is possible with these kinds of 3D printed appliances. And so we have the ability to make the straps of different materials, because that gives us feedback as to how comfortable. In other words, the shorter the time frame that it takes to stretch these bands out means that the patient is struggling. And this gives us feedback to know how we can go about treating people. We should know that very often people can't tolerate CPAP. However, when they're combined, an oral appliance and CPAP are combined, that seems to work very well for people. And we find in paper after paper that this is possible. And so this is a customized combination appliance that we have come up with, that now the delivery of positive pressure in combination with an oral appliance. So the oral appliance is keeping the airway open. Now delivery of CPAP for these really severe cases, we're able to get the CPAP titration down to its lowest setting, around 4 centimeters of water, which makes it very comfortable. And there's no straps on the person's head with this technique. So this is very comfortable and allows to handle the toughest patient. So this is an example of how that works. This is a patient who's had was in terrible straits with a motor vehicle accident, had multiple injuries. So she resulted in headaches, jaw joint problems, severe OSA, and we use this therapy for her. I'll let her tell you.
Oh, before I started the treatment, I was in so much pain. I didn't know even what was wrong specifically. I wasn't sleeping. Sleep quality was terrible. I would wake up with a lot of pain during the night. Chewing I've been on a soft food diet for close to 4 years, and being able to start chewing food with the mouth guard has been helpful. And I don't know where to start. He's helped me so much with sleep and my jaw pain, headaches, my balance of walking and standing, and just so much of my pain is decreasing. My neck, my arms, I can feel my skin after the physical therapist works on me. The therapy is, her therapy is sticking more after using Dr. Olmos' program, and I just loved his whole looking at everything, diet and inflammation and pain. I remember one of the first things he said was that he wanted to help me get out of pain, and he is, and I can see the light at the end of the tunnel. And I'm just amazed at how basic things in life can exacerbate other injuries, like sleeping and breathing being so important to how the rest of our body functions. I just feel so grateful that he is part of my support team and working with my other practitioners to help figure out what people haven't been able to figure out so far. He's figuring it out.
So I'd like to finish up by just saying that we didn't have time to talk about children. I was just lecturing at a symposium here in the US that I created back at the University of Tennessee 5 years ago that's been ongoing, and bringing physicians and dentists together to help in trying to build bridges. And I'd love to have an opportunity sometime to talk about that at a later date. If you would like some information about basically how to treat these things, the current edition of the Journal of Orthodontic Practice is devoted to TMD and airway disorders. And I was asked to write the introduction to this journal for this specific topics. And essentially, orthopedic intervention as early as possible is key. But we always wonder, what are we treating to? And I think that question was answered. So, excuse me. So in quoting my article, the question that we are left with is, what are we treating to? The answer to that is given to us by our seminal figure in pediatric sleep medicine, Christian Guilleminault. And so this is the person who developed the AHI system that we currently use. Even though now he's, when he was alive, unfortunately, we lost him 2 years ago, but he adamantly said that that's oversimplification. But he says, really what we need to do, he says, elimination of oral breathing, i.e. restoration of nasal breathing during wake and sleep may be the only valid endpoint when treating OSA. That's what we're treating to. So we need to understand that the treatment of skeletal deficiency, the orthopedic orthodontic development will result in improved breathing, reduction of facial pain, headaches, bruxism, and dental facial orthopedics started as early as is possible is the key to improving quality of life. And that's essentially what I've summarized in the small book that I've written that gives this kind of point of view to understand, well, why are so many people having chronic pain issues? And really understanding that we're not appreciating the fact that the highest priority of life is the least evaluated by healthcare professionals. And so I'd just like to say thank you. I really appreciate the opportunity to share ideas. And this is quite an honor for me. And I'm open to take any questions you might have at this point.
Thank you, Steve. Wow, overwhelming. absolutely overwhelming. Thank you. We are most appreciative for your beautifully prepared, comprehensive, enlightening, and fascinating presentation, Steve. I've been following your work for 10 years. I've communicated with you over the past 4 years. And it would be an absolute pleasure for us to welcome you in South Africa sometime. And of course, also have a TMJ center established in South Africa. It's my absolute dream. I just wish I was a lot younger than I am at the moment, but it's not out of the picture. You are such an inspiration, excuse the pun. And I'm really most appreciative of you taking the time to do your presentation. I've always felt I've been involved in dental sleep medicine for the past 10 to 15 years. And one of our biggest challenges is educating ourselves as a profession. Yeah. And once we've done that, is to encourage our medical colleagues, obviously, to become involved and to see the value of what we're doing. And that's why when you finished your presentation, I said overwhelming. I think a lot of our younger colleagues, and I'm privileged in South Africa to be of an age to see the most amazing young colleagues coming through. They are bright, they are keen, they see that there's a change needed in dentistry. Share your thoughts. How do you feel we can go about changing things?
Well, I really feel that we need to go back in time. Here in the States, there was a time where dentists and physicians were educated early on together before they were separated into specialty, And I really feel that the dentists are missing out on that essential education. I think dentistry is going to evolve, and it really has in a lot of areas. I've spent a lot of time in Australia, probably the last 20 years teaching courses down there. And that's where I really saw the separation, where there's dental technicians and then essentially dental physicians. And, that's now migrated to the States, and we now have similar situations. And I see that as the future. We're going to have dental technicians that'll do the operative type procedures and this sort of thing. And then we're going to have dental physicians that are going to handle this crossover in the area that essentially the kind of things that I do. I think we have a specialty now in the States, orofacial pain specialty. And I think people try to separate orofacial pain from sleep disorders. We have different academies and we have different thoughts, but reality is these are highly comorbid. And I think there needs to be assimilation of that and an education that is combined. And I think if we got education from the standpoint of understanding the physiology and anatomy and function, as the physicians do, I think we would be better able to help people. And so, I'm excited for the future. I'm excited for these young minds. And I hope that I see the problem is that we have the educators who don't have background in these fields. And so who's going to teach these great young minds? Who's going to, we have a big change that's needed in the States. It was 4 years ago that sleep medicine was first introduced and as a requirement for dental school curriculum. So prior to that, there wasn't any. The amount of time that's devoted to sleep and TMD in most dental school programs is about 1 hour per year. And you know, I thought that was unique. I thought it was just dentistry that was so undereducated, but it come to find out that in medicine is the same. They get less than 1 hour per year on sleep related pathologies. So all of us, all healthcare practitioners are undereducated in this field. And that's what I hope that the emphasis changes in the future.
Absolutely. Thank you, Steve. You echo my thoughts absolutely. And that's the whole thought process behind the Dentistry's Great Awakening series, is to enlighten our colleagues and to expose the fact that there's a whole new world out there that we are very well suited as a profession to get involved in. Right, you're not going to get away that easily. Seeing that we have you at our disposal, there are questions that need to be posed. So the first question I'm going to ask is, do you, gosh, wait, let me just find them. Open the three. Yes. Do you think that sleep apnea is a modern phenomenon in the human timeline? In other words, post-agricultural era, industrial revolution period?
Yes, absolutely. If Kevin Boyd, who's a pediatric specialist here in the States, does really good educational programs explaining how our skulls have reduced in size. There was a time where we had room for 32 teeth. Now, in most civilized or developed countries, we because of our diet, we don't have room, and so our airways are very much underdeveloped. Going back to the 20s and looking at Weston Price's work and demonstrating the differences between nutrition, between industrialized high carbohydrate diets to indigenous diets. Absolutely. And the prevalence rates of breathing disorders are going up incrementally, as well as obesity and all the consequences of those things. So yes, I completely agree with that.
Absolutely. And Steve, another question is there still a place for traditional occlusal night guards? Now, if I could maybe just expand on that from my perspective, I think what the person is asking is there a place still for the use of the maxillary Michigan splint? And or is there still a place for the use of the softer thermoplastic mouthguard type materials in the treatment of temporomandibular joint conditions, etc.?
Well, it depends on what the origin of the parafunction is. So in order for you to have a parafunction, there has to be a cortical stimulation. So is that arousal the result of pain? Let's say a person has a chronically inflamed hip or back, or whatever chronic injury that isn't being addressed or can't be addressed. And so is that the result of that activity? Or is it a respiratory reason? Is the person, mouth breathing, or they have a pharyngeal collapse of the airway in the unconscious state? That's to be discerned. So if there is parafunction, in other words, you need to understand what category is this in? Is this a primary bruxism or a secondary bruxism? When you make a diagnosis, a primary bruxism means in the absence of a medical disorder. So have you checked the person for a sleep breathing disorder? Have you checked them for any kind of respiratory reason? That would be a primary reason. A secondary bruxism is the result of a medication. In other words, a lot of the medications that we give for poor sleep actually worsen sleep. So we give different kinds of antidepressants, selective serotonin reuptake inhibitors, increase parafunctional activity and then result in headaches. So what exactly are we treating here? And that needs to be discerned. the thought process that we put a night guard in, what really is its purpose? It prevents the wear of the dentition, but I can't tell you how many patients I see on a daily basis that come in with multiple night guards made over their lifespan, and they have severe osteoarthritic problems because the jaw can still move. So it's not limiting function of the jaw. So, and if the origin parafunction hasn't been addressed, then that isn't a solution. I think we need better evaluation techniques and better screening. And I think we'll make less night guards. In my practice, that's limited to treating jaw joint disorders and breathing problems. I can't tell you the last time I made a night guard. I would see an indication for somebody that maybe fractured their jaw. Maybe you have a high condyle neck fracture, maybe you have something like that, where you want it to heal, but you don't want interface between the teeth. Okay, that'd be an indication. But short of trauma, I actually make appliances that reduce the ability to clench and parafunction. So I might have more of an anterior disclusion than posterior disclusion. So in my practice, honestly, it's quite limited because I'm actually spending the time to find the origin of the problem. And so the devices are more specific in that way. So I'm sorry that was long-winded, but I think diagnosis is 95% of effective therapy. And so I think we need to spend more time figuring out why.
Exactly. Treat the cause and not the symptom. Absolutely. Steve, let's see. Another question is, have you had medical practitioners think that you are intruding in their domain of medicine?
Not at all. The opposite. I have partners in practice, and certainly it's taken a while for people to appreciate, but I think in all situations, people want referrals, and so in over time, you want to establish a referral network that is like-minded. You want people to be as good at what they do and be as conservative in terms of their therapy, but effective in the delivery as you would like to be. That's my perception. And it's taken me some time, but now I've established really great relationships with otolaryngologists, with sleep physicians, with neurologists, psychiatrists, all different specialties of medicine that are thankful that they can refer their patients that they can't help to me for the things that I can do. So we're more of a partnership in it, and it's quite a nice working relationship. I do think that takes time. I think that takes education, and certainly, I've been doing this for a long time, but building bridges is what I'm all about. So I tried to do that in a local level where I live here in San Diego, but I'm trying to do that, throughout the world. I can't tell you how many medical schools and dental schools I've lectured at, trying to build these bridges. And it's really just about educating the physicians at the services that we can provide. They just don't know that we can. And the paper that I just spoke about that we're about to publish, correlating nasal obstruction and facial pain, my goodness, when that gets published, I have so many ENTs that are ready to duplicate that paper in the ENT literature. So we're on the verge of making some really great connections, and whatever we do here, I know will trickle out to the rest of the world. And that's why meetings like this, this is so valuable, the service you're doing, because this is bringing awareness. All we need to do is bring physicians into this and make presentations like this. in a joint format. That's why I was showing the slide about the pediatric OSA. We're bringing the top physicians in with the dentist and then showing how we can work together. And if you get the right people, they're going to appreciate that. Yes, there's always the person who, might be a little resistant to it, but that's a little bit of bias and ego, and there's always going to be that, unfortunately. But if you get enough of the good people, and they're out there, believe me, they're in South Africa, they're everywhere. We just need to get them all together. And I would love to come down there and be a part of something like that. And if we need to bring people, physicians from the States, maybe we could do that. And but we got to get this message out. We've got to connect with all the like-minded people. They're out there. I know they are.
Absolutely, absolutely. And the time is now. There's no better time than the present. Steve, the questions are coming in thick and fast. Given your background and knowledge about temporomandibular joints, the one question is, can or does orthodontics cause temporomandibular joint dysfunction?
No, I don't believe so on the most part. I think very often traditional orthodontic therapy is all about alignment of teeth, and so the thought process of extraction of teeth to the space provided, I don't think affects airway in that way. So a lot of times people are wondering, does extraction of teeth make people have apnea? No, I don't think so, because they're not really changing the structural component. However, retractive orthodontics certainly is going to have effect on orthopedic problems of the jaw. So if we're retracting the maxilla and the mandible, well, obviously retruding that is going to lead to some kind of disc displacement issue. Isn't it interesting that the surgery that's most effective for breathing disorders and pain is maxillary mandibular protrusion, sliding osteotomies. So I think anything that retracts is going to affect the jaw and breathing. And anything that protracts will have the opposite effect.
Absolutely. Thank you for that answer. And then another question is, can the TMJ joint remodel?
Oh, yes, absolutely. In fact, that's something we see fairly routinely. We take x-rays at, a new patient first visit, and then we take x-rays at the termination of our treatment, which is about 10 to 12 weeks. And I'm amazed how much remodeling and healing that we see in a 3-month period of time. It's really quite remarkable. I was doing a study where we were trying to find a software, and right now there isn't one that exists in North America, that could actually take the cone beam CT and measure volume changes. And because we were seeing these remodeling, so pitting and cratering of the surfaces of the condyle would fill in, and so the volume doesn't increase in volume, okay, but it remodels, and we see that all the time. That is fairly consistent. It's actually quite rare that I have to send a case out for surgery. Most of cases that I treat and our centers treat have dramatic improvements in osteoarthritic changes, and reduction of long-term changes. And that's really the key. We get a person at any point in time, and so what we're trying to do is heal whatever disease process they have and prevent it from progressing. So osteoarthritis will deteriorate over time untreated. However, you have to understand that osteoarthritis is just an overuse issue. It's overuse of the joint and in a parafunctional way. So if you control the origin and the parafunction, and then eliminate or reduce the inflammation, absolutely you can maintain that.
Wonderful. Thank you. That's just so encouraging, because there's this thought process out there that the temporomandibular joint can't remodel, and it just doesn't make biological sense that it
I completely agree. You know, all other parts of our body heal. Why can't it's not like it's a genetic disorder. It's the result of overuse. And so
absolutely. Absolutely. And of course, on the question of parafunction, this is something that we all experience in our practices on a daily basis. A mom will bring her 4-year-old child in and say, my child is grinding their teeth. The question is, where do we start with answering that question?
Well, you know, breathing disorders like obstructive sleep apnea, you're born that way. Dr. Guilleminault was showing that even in utero, you can measure the facial angle, and if it's less than 65 degrees, the likelihood of a person having a breathing disorder is quite high. So, you know, these are inheritable processes. So if you know, that's really where we need to go is screen pregnancy for sleep breathing disorders, because 50% of all high-risk pregnancies are the result of some sleep breathing disorder, the hypoxia of the mom and fetus. So we need to understand that it's from inception. So, you know, these kids can't breathe. That's what we see with SIDS, sudden infant death syndrome, is really a breathing disorder. Guilleminault talked about that, how that was really pretty much a complete nasal obstruction situation. And when you see kids parafunction, they're grinding their teeth down, that is a very, very high sign of a breathing disorder. And we can treat those things in a myofunctional way. Usually from the age of 2 to 5, we treat that myofunctionally, using myofunctional techniques and things like that to strengthen the tongue and the lips so that the tongue develops the maxilla. And for every 1 millimeter of transverse width, we get 2.35% increase in nasal volume. And every 1% of increase in nasal volume is a 4-fold greater flow rate. So these don't have to be great changes to have great effect on breathing. And we just need to get better understanding of how we intercept these things at inception.
Absolutely. Thank you, Steve. From that, the question arises, does bruxism serve any good purpose at all?
Well, yes, there's a normal rhythmic masseteric muscle activity. All of us have some kind of movement, rhythmic movement. It's when it becomes excessive that becomes issue. And so that's really the key. So in growth, there's a piezoelectric force that stimulates bone growth. And that's why we need to have kids eating real food at the earliest point. You know, this tendency to give children baby food that's just mush is really contributing to the underdevelopment of the mandible and maxilla. The torsion that happens through chewing is the stimulus for the growth, and so we need to get kids eating real food as early as is possible in order to have proper development.
Absolutely. And Steve, then, oh gosh, I've lost my train of thought now, but let me just revert to some further questions. Yeah, no, there don't seem to be any further questions. Just if I could ask you a question. I use the echovision, rhinometry and pharyngometry extensively. I use it not as a diagnostic tool, but I use it as a screening tool. Pre-treatment, intra-treatment, and post-treatment, obviously. Now, most of the work that I've seen done with the Echovision is when folk are in an upright sitting position. I do that as a baseline, and then I also put my patient back onto their backs, and then I do especially the pharyngometry, and I do it with and without the appliances. Do you feel that am I missing something, or do you feel that there could be value to doing the pharyngometry when someone is on their back?
Well, studies have already been done on that, and it's been demonstrated that position doesn't matter in the conscious state. And the reason why is that your brain will maintain an airway regardless of position in the conscious state. Sleep breathing disorders, obstructive sleep apnea, is a problem of the unconscious state, and that's always the issue. How do we evaluate how the airway changes from the conscious to the unconscious? So that's why they use drug-induced sleep endoscopy, where they'll use a camera and sedate the person, conscious sedation, so that they can get an idea of how the airway collapses. If it collapses in an AP, anterior posterior way, then that's likely something we can help with an oral appliance. If it collapses concentrically, that's something we're not likely to be able to help with. And so that's more of the important information. Yeah, I remember years ago when I was kind of investigating, like 20 years ago, when I was first introduced to using this technology, that was the point. How do we reproduce what happens when you're unconscious and the conscious? And so, the best way that we could come up with was just simply measuring resting volume and then asking the person to expend all their air. So whether you're upright or laying down, dynamics are fairly the same. And actually, they just, I think it was a year or two ago, they just did that study on children to see if there was, because children's airways are different if they have OSA. If they have OSA, head posture seems to make a difference on the airway, where in kids that don't have OSA, it doesn't make a difference. So there's a lot to understand about position, and that's why in our paper that we published back in 2007, we looked at that. We looked at, does it make a difference in what position? And we found it really didn't make a lot of difference in the conscious state. And so, we're interpreting the conscious to the unconscious. Is it apples to apples? No. But is it the closest we can get without an invasive procedure? Yeah. And when you talk about how do you treat the masses, I mean, these problems are prevalent. We're surrounded by them regardless of where we live. And so how are we going to get to address all these people? We can't be doing drug-induced sleep endoscopy on every single patient. It's just not possible, but using the type of technology that you and I are using, well, that's possible. And so that's why I think what we're doing is something that can be taught to dentists, can be integrated into a practice where these things are evaluated and treated. And I think it's the closest we can do without sedating the patient and having a surgical procedure.
Absolutely. It's non-invasive, it's painless, and it's just a very good screening process. And it's a case of conscious self-regulation or self-control of your breathing, unconscious sleeping, self-regulation. And it's with the self-regulation that fails. I also use capnography. I use the Capner trainer. I did Peter Litchfield's master's course, and I find that very useful as well. Good. So I think
very accurate. Yeah, that's very accurate, because the body is sensitive to CO2 much greater than O2. So that's a really good technology that you're using. Yep.
Yeah, absolutely. Right, Steve. I think we've hit the button and in terms of time. And once again, words can't express my appreciation to you for your time, your knowledge, and your expertise. It's been an absolute privilege and an absolute pleasure for me to have had you on the Dentistry's Great Awakening series. We've really, there's no doubt that every single person who's been on this, listened to this presentation has benefited. And it's my wish, again, to get you here so we can start expanding minds and changing attitudes. Take care.
Thank you. Thank you so much.
Take care. Have a wonderful Friday and a good weekend. And although I don't know them, love to your family.
Oh, appreciate that. Thank you so much.
Thank you, Steve. You take care. And I'll be in touch.
Okay. Look forward to it.
Thank you.